Assalamu alaikum, everyone. This one once again, Dr. Afia Shah. Today, I'm going to give you an idea about how to solve the MCQ and what are the MCQs actually coming in the exam. Some of the MCQs I remember of my previous exam, so I've shared over here. Before I shared with you all the topics, the important topics, which I came across during my exams. And now, today I'm going to share some of the MCQs with you, also some BCQs. And also over here, I'll be giving you a little idea about in detail, if you solve the MCQ, if you study, then some of the questions related to the same topic when they give in the time of your written exam, that is for MFD2. So like, how will you prepare? And that how will this preparation in a little detail will help you there. So as I told you in my previous tutorial that the DipPCD or Diploma in Primary Care Dentistry exam, it consists of MCQs as well as PCQ exam. MCQ are around 75 and they give you 15 BCQs. BCQs are best choice answer, means you have to only take one of the answer which you feel that is appropriate, and in MCQ you have choice to, you can choose 2, 3, like that. It's multiple choice question. So we have 75 multiple choice questions there, and we have 15 single best answer questions there. So 2 topics I'll inshallah discuss over here. They will give you more idea about the exam pattern, as well as in this tutorial, you will come across 5 questions which I remember that came in my exam. I have discussed over here, and the rest inshallah in the upcoming sessions I'll be doing. So let's proceed. These are the last topics. These are the actually topics which came in my exam and which I've already shared with you. Out of these topics, I have chosen these 2 initial topics. What is implant mucositis and what is tongue embryology? I have discussed these 2 according to exam, and you see the pattern I studied. According to that, I have made my presentation to help you most if I could do. Coming to first topic, as I told you, we will be going to talk about implant mucositis. See, studying quickly about the implant mucositis, I think does not make any, effective study. When I do not know what is it actually implant, and I have no idea what are the parts of implant, what is the purpose of implant, then understanding this mucositis of implant will be of little use. But if I have good depth of knowledge about the exact the question, what is the question talking about, like that is implant, and I will have a depth knowledge about it, then I would be able not to only answer the question which is coming on implant mucositis, but they do give 2 or 3 questions from the implant, so you'll be able to cover most. So let's begin with what is implant mucositis. Before that, I shall give you an idea about what is a dental implant. That these are prostheses. If given in dentistry, these are called dental implant. If given in other parts of the body, they are given different names. Why are we giving dental implant? It is nothing but it is actually a material, a biocompatible material, which is inserted into our body just to give support to the prosthesis. So in dentistry, we are using it mostly to support the prosthesis. What is prosthesis? Prosthesis is an artificial, if we are talking about tooth, then it is an artificial tooth or man-made tooth which is given to a patient. So how the tooth which are giving or inserting into the patient's cavity, if patient does not want the rest of his teeth to be compromised, like patient is having these and these two teeth are present and this of the tooth in center is missing and patient wants me to give him prosthesis, I say, okay, cut this tooth, I'll cut this tooth of you, and then I'll give you a bridge. Patient say, no, please don't give me. I don't want to compromise my other teeth. So the option I get is that I shall give this patient an implant, that artificial substitute of a root, and I can give a prosthesis to the patient. That's why we need an implant, and that is actually an implant. So in dentistry, the purpose of giving implant is to replace the lost root portion. You see here, this is a picture of an edentulous patient. Here we are going to give the implant. How will artificial teeth rest on this arch if you want to give a fixed prosthesis? There are two types of prosthesis, removable and fixed. I'm not talking about prosthetics right now. I'm just trying to make you I'm trying to bring you towards the fixed prosthesis. And for that fixed prosthesis, we need an implant. So what will this implant do? That implant will help me. It will get attachment with the bone. Some part of the implant you can see resting outside. Some of the part of the implant is embedded in the bone. And this implant will help me in supporting the prosthesis which I am going to give to this patient, like these teeth. They'll be supported. So that is called fixed prosthesis, and that will be only attached by means of these screws. These are called as implant. There are three types of implants. Most commonly used is endosteal type of implant. There are three types of implants used in dentistry. One is endosteal, one is periosteal, one is zygomatic. But the most common and safest is endosteal that is used. Subperiosteal and zygomatic are least, the last choice of a dentist. I'll be just talking about the endosteal type of implants, and because we are mostly using them, what are these implants? These are the implants which replace the root. Means they will be serving as a root for my artificial tooth, which I'm going to give over it. And that will get itself attached with the bone, my jawbone. Will it be firmly attached to my jawbone in order to support my artificial tooth, which I am going to give over it. So I said we have to focus on endosteal type of implant because it is most commonly used. So among these, endosteal is most commonly used, and these endosteal implants are of three types. One is screw type implant, the simple implant like a screw. One is a cylinder type of implant, and one is a blade type of implant. The difference between these all implants are, you see, the screw type of implant and cylinder type of implant is having some difference in shape, difference in design, but most commonly preferred again over here is a screw type of implant. There are different conditions where different type of implants are used. So that before understanding the topic of implant mucositis, now you understood what is implant. Now you will be able to understand how this mucositis is occurring and what is actually it is doing and where it is occurring. Now you have a little overview about implant. Now, before switching to the mucositis, I shall tell you the components, the part of the implant. We are talking about the screw type of implant. You see, this is the part of the implant, the screw which is embedded in the bone. That is actually replacing your root, the root of a tooth, over which a little piece, another piece of an implant that is called as abutment. That abutment is the one which will be, part of it will be attached to the implant and part of it will be attached to the crown, which we are going to make, or which we will be, or that will be custom made. So this implant has a part which anchors the artificial tooth with the bone, and another part of that implant, this hole, you see, this part of the implant is 100% embedded in the bone, the screw type, the screw part. Very little of it, can you see, is out, present. In this little portion, this rest of the portion, when we will put inside, then the height of this will be up till here. Now we will have a kind of a little material, the tooth material and the root material, which we embedded inside. That remaining, this piece of an implant, that will be representing a little of your crown portion. This represents a little of your crown portion. So that will help us in attaching the artificial crown over it. To understand where to give implant, what shall be the position of the implant, what should be the depth of the implant, what should be the width of the implant, it is very, very important. And how much space do we have where we are supposed to give what diameter of implant. So please do understand these things. These are very little things, but very important. For example, this edentulous space, this space where we do not have any of the tooth present. If this space is narrow, like 3.25 millimeter in diameter, then in this space, we will give implant of 6 mm size. If I consider this space is 3.25 mm, so to this space, the implant which I will give will be not more than 6 millimeter. Sorry, the space is 6 millimeter, I'm sorry. The space is 6 millimeter, the edentulous space is 6 millimeter, like here. The 6 millimeter space is edentulous area, which do I have? Here I will give an implant of 3.25 millimeters, not more than that. But the same space, if it is 7 millimeters, I can give here an implant of 4.1 mm. That is the standard size of implant. But if this space, the edentulous space is 5 millimeter wider, 8 millimeter wider, means double of 4, or as earlier we said, if the space is 6 millimeter wider, then 3.25 millimeter implant. If we said the space is 7 mm wider, the implant size increase. If the space is 8 mm wider, the implant size will increase more. If the space is 9 mm, then you give 6 mm implant in width of the implant. We are talking about this width of the implant. But if you have a space of 14 millimeter, then what will be the width of the implant? Shall I rise the width of the implant to, for the space of 14 millimeter, shall I give one implant and rise its width? No, because space is very wide. So here we can give 2 implants of standard size. As I told you, the standard size implant is 4.1 millimeters. Please remember this. This can come in the MCQ. What is the standard diameter of an implant? The standard diameter of an implant, we are not talking about length, we are talking about the diameter of implant. The diameter of a standard implant is 4 millimeter. When you have very large space or very wide edentulous space present, over there you cannot give one wider implant. You can divide it into 2 implants of standard size. That is based upon the edentulous space you have and what shall be the diameter of the implant. Now coming to structures, means minimum space or minimum diameter required in all 4 directions. Means if you say this is the edentulous space, see, this edentulous space is having the mesial surface to it, the distal surface to it, the buccal bone. On the other side, it has a lingual bone. Then if we are talking about the lower arch, then it has an inferior alveolar nerve present because it is the posterior side of the arch. So if we talk about the upper jaw, then there can be vital structures like maxillary sinus present. There can be nasal cavity present. So from all the direction, there is some standard distance an implant is supposed to have. So what are those distances when we are planning an implant treatment? What are those distances are to be considered before placing any implant? Now see, if you are giving an implant, for example, I'm here. I'm giving implant over here, and the surface, this surface, the outer surface is the buccal plate. So the minimum distance between the implant and the buccal plate should be 0.5 mm. As I'm giving implant in the lower arch, so you know that in the lower arch, this is the inferior alveolar nerve. If I draw the inferior alveolar nerve somewhere here, you see here, this implant is very prone. When I place the implant, it is very likely that I can harm the inferior alveolar nerve. So while placing implant in the lingual arch or in the lower arch, the distance between the implant and the inferior alveolar nerve has to be at least 1 millimeter. Same is if you are giving the implant in the upper arch, you have maxillary sinus, you have nasal cavity, you shall be at least 1 mm away from the anatomic structures. And also, as we said about the buccal plate, it has to be 0.5 mm, but for the lingual plate, the implant and lingual plate distance should be 1 millimeters. Coming to, now this is with the bone, with the vital structures. Now coming to the other structures which are nearby implant. You see, this implant is having a tooth adjacent to it, the natural tooth adjacent to it. An implant has to be 1 mm to 1.5 mm away from the natural tooth. 1 mm to 1.5 mm away from the adjacent natural tooth. About the inferior alveolar nerve, over there I said 1 mm, but you shall be 2 mm away from the inferior alveolar nerve. This is actually the inferior border of the bone. You have to be 1 mm away from the inferior border of the bone. Now, if you are giving 2 implants on one patient, as I told you that if there is a wider space, here you are supposed to give 2 implants. So how far an implant be from another implant? They shall be at least 3 mm away between the outer edges of the implant. They shall be 3 mm away. I'll explain you with the picture. In case of, again, into the anterior region, if I'm going to give the implant, I shall be very careful about the other nerves. Like I was taking care of the lingual nerve in the posterior region. Similarly, I shall be careful about when I go forward and giving implant, I shall be again very be cautious about the mental nerve and incisive canal. Incisive canal in the anterior maxilla. And I shall be careful about when I'm coming to the canine region in the mandibular arch, I shall be very careful about the mental nerve because the mental foramina is very near. So there are some standard distances which we are supposed to be very careful before the application or before the insertion of the implant. So please do remember these charts. As I told you here, if we are going to give 2 implants into a wider space, 2 implants into a wider space, and here, as I told you, a natural tooth and in the implant distance, how much shall it be? We said it has to be 1 to 1.5 millimeters. But if we say, I'm going to give 2 implants into a wider space, we said at least from the outer surface to an outer surface of an implant, there shall be 3 mm distance between an implant to implant. Why do we require this distance? If you will be placing implants very near to each other like this, where will you give this crown then? Where will you give this crown? Because you are replacing a very large tooth. For example, here I say this is the second molar or second premolar, and this is the first molar. And I'm going to replace the first molar. The space is very wider. So the distance between areas where the 2 implants are given, we shall have 3 mm space between an implant surface to an implant surface. As in this picture, between this implant to this implant is 3 mm space. And if we see between implant exterior surface to another implant exterior surface, the space is 3 mm. What about a natural tooth? From exterior surface of an implant to a natural tooth, there shall be 1.5 mm distance. And this is, we are talking about the wider space, the 14 mm space when we have present. I hope this is clear that the exterior surface of implant adjacent to the tooth, the natural tooth, there should be 1.5 mm distance present. The exterior surface of an implant to the exterior surface of another implant, there shall be 3 mm distance. Where there is a wider edentulous space, we can give 2 standard size implants. And those standard size implants are 4.1 millimeter wide. Now that is all about the implant. Now coming to implant mucositis, it was questioned in the exam. First, you understand what is implant mucositis. You see, the word is telling you that some itis stands for inflammatory condition. Means there is some inflammatory condition. Inflammatory condition of what? Mucosa. Where? Near the implant. The word itself is telling you that what is the question talking about. The inflammatory condition of the mucosa near the implant. Here, inflammatory condition of the mucosa near the implant, that is called as mucositis, implant mucositis. So implant mucositis is nothing but it is actually an inflammatory condition that occurs around the implant, which is embedded into your bone, and that causes the inflammatory condition. Why these occur? We do call them also peri-implant disease or peri-implantitis also. Peri means around the implant. So there is a little difference between implant mucositis, although it is a kind of a implantitis, but that is mucositis, and other is a peri-implantitis. Only the difference between these two is in implant mucositis, you have inflammatory condition present into the mucosa, but no bone loss present like this. No bone loss. This is the natural bone loss which was already present, but no bone loss, only the inflammatory condition around the mucosa present. But if it turns, if you don't treat and the patient does not come to you, then it can turn to peri-implantitis, and that is a destructive condition where your bone surrounding the implant gets inflamed, and with the passage of the time, that bone is removed, that is present around the implant, that will be removed by the osteoclastic activity and inflammatory condition, and ultimately your implant becomes loose and failure. I hope I'm clear. So Implant mucositis is an inflammatory condition where you do not have any bone loss. But peri-implantitis, again inflammatory condition around the implant, that causes alveolar bone loss, ultimately failure of the implant. So in our exam, we had a question from it. What is the treatment of peri-implantitis? You can give surgical treatment, you can give non-surgical treatment, you can do surface decontamination. In non-surgical treatment, when the patient is coming to you, you see the condition is not bad, and you can, give mechanical methods of toothbrushing to the patient, how to clean the oral cavity. You can prescribe antibiotics depending upon the condition, and you can give antiseptic solutions. With the surface decontamination, which surface to decontaminate? There are in the market, there are implants which are pre-treated implants available in the market. We can use those implants as well, or the implant which is loose, which have gone to the failure. We can treat that implant with some chemical methods like citric acid, EDTA, hydrogen peroxide, or saline. We can treat that implant outer surface or implant surface with those chemicals. We decontaminate them, and then we can again insert into the patient's mouth. Then we have surgical treatment. In surgical treatment, you have air power abrasive method. Then we have implantoplasty, or we have regenerative surgery. Regenerative surgery, you said, you remember I told you that in peri-implantitis, you have a bone loss. Now, from where will you bring the bone back to support the implant? So you can take help of guided tissue regeneration, guided bone regeneration, these artificial methods of, growing the bone again. And we take the support with those materials, then we place the implant, and then we wait for the results. But these conditions only depend upon the severity, what level of the severity present. So what are those conditions which cause implant failure? These are actually, number one, presence of biofilm. Presence of biofilm means your patient is not keeping oral cavity clean. There is an accumulation of tart calculus. From that calculus, if the patient is negligent of maintaining oral hygiene, this calculus, from this calculus, the microorganisms invade deeper and deeper and deeper. They cause the bone loss, inflammatory condition. There is increased, implant mucosa interface. Like you see here, implant, this bone was supposed to be present over here, but due to inflammatory condition, you see this bone, and due to the loss, there is increased gap created between the implant and the mucosal surface. So that is permitting the passage of microbes to invade more deeper and deeper and deeper, and bring the condition to more severity level, and ultimately the bone loss and failure. But implant mucositis, as we were discussing about, it is a reversible condition. It depends when you remove all the etiological factors, you provide good oral hygiene instructions to the patient, you remove the calculus, you provide good scaling to the patient, then the condition can reverse depending upon some other factors that help in implant success. Those factors which help implant success, number one, very important, is the etiology, the patient's own oral habits. If the patient is negligent of maintaining oral hygiene, failure. If patient is smoker, failure. If patient is negligent, about taking care of his implant, failure. They all lead to origin of the infection, and once infection is established, with the passage of time, implant fail. And once the implant fail, there are least likely chances that the implant can improve even with the regenerative materials. So That was all about implant mucositis, the factors that were causing the implant mucositis. As I told you, please remember, number one, the bad oral hygiene. Number two, patients' own oral habits like smoking, like patients taking alcohol. Do remember the systemic conditions of the patient, like patient is diabetic, they do have most likely chances of implant failure. So based upon the implants, I have brought some of the questions, some of the MCQ and some of the BCQ. Let's solve. Clinical findings of failing an implant include, how do you know after examining clinically? How do you know when a patient comes to you and for the first time you see the patient and you need to find out clinically that is your implant failing or not? What first thing you see in the patient's mouth? If inflammation present around the implant or in the mucosa? Bone loss, you cannot see the bone loss with the naked eye. You can see the probing depth by means of a probe. You can see the depth of the pocket and you understand, okay, the pocket depth is increased. It means there is something wrong. And pocket depth is self. The bone loss can be found on the radiograph. All these factors, when they present, will they be helping you in telling that whether implant is failing or not? So answer is yes, presence of inflammation, progression to bone loss, the formation of the pocket, not none of above. All of above are the factors which cause failure of an implant. Question number 2. A history of a dash has impact on the success of implant. Patient with history of diabetes. Think of it. A diabetic patient having an implant. Do you think it affects the success of an implant? Yes. Pre-prosthetic surgery, does it really affect the success of implant? No. Periodontitis, does it really affect? Periodontitis, or you can call it periodontitis, whatever you want to call it. Yes. Traumatic extraction, the place where you are going to give implant and you did traumatic extraction over there, does it really affect the success of implant? No. What about smoking? Yes, I told you, etiological factor for the failure of an implant. So this way we need to answer, we need to understand by keeping time in mind, and such way we can, with the knowledge, we can understand, because we had a little idea before about the implant because we studied the etiological factor, the causes of the failure, what is implant and all that. So we came to some of the conclusion that helped us solve these questions. Inflammatory changes in the tissue surrounding an implant is diagnosed as, you see, the question is telling you that the question is asking you only one thing. So this is a BCQ, best choice answer or best choice question, or you can call it a best of 5. The question says that inflammatory changes in the soft tissue surrounding an implant. Soft tissue surrounding an implant. Is it peri-implant gingivitis? Is it peri-implantitis? Or peri-implant mucositis? Soft tissue, mucosa. So it is peri-implant mucositis. Most plausible factors for dental implant fracture. What are these? Most plausible factors for dental implant fracture, although we did not study, but we can use some common sense. It is not talking about inflammatory condition, it is talking about fracture of an implant. How will the fracture occur? It means there is some problem with the prosthesis itself, or maybe the designing of implant, maybe the loading angle of the implant. Means that has nothing to do with oral hygiene of the patient because it is causing fracture of the implant. The question is talking about something else. So common sense that the question is not talking about peri-implantitis, inflammatory condition. Non-passive fit prosthesis, manufacturing imperfections. Implant fracture is least caused by manufacturing imperfections. That is mostly caused by loading. When a dentist is working, when the dentist is loading an implant, that is actually mostly that affects the implant life. If the loading angle is not proper, the angle which implants makes with the bone, if that angle is not proper, then there are chances that the implant will fail. You see here, this is the bone, and here, for example, I say the implant has to be at 90 degree with the bone. But here I give an implant. For the first time I'm giving implant, and I have given this angle to the implant. This is not 90 degree angle. So the implant will fail. As soon as I give prosthesis to the patient, the prosthesis will fail. The distance between an implant and adjacent tooth should be, I told you, the distance between an implant and the adjacent natural tooth has to be what? Let's go and see. If you don't remember, what is this? The distance has to be 1.5 mm. So the distance between a natural tooth and implant is 1.5 mm. This is the answer. The minimum mesiodistal space required for two standard diameter implants between teeth is, what is the mesiodistal width of two standard implants which are giving between the teeth is the minimum mesiodistal width required. Where, in which space can I give two standard size implants? What was the space requirement for the two standard size implants? Do you remember? It was, we said we can give two implants of standard size when there is 14 millimeter of space present. The wider space is there. So the answer is 14 millimeters. It's very important to know, I have given this picture from the books which are used for MFD2 exam. See, telling you or not for only the MCQ or for the BCQ of part 1. This way, if you study in a detail, will help you for the part 2 exam, because in the part 2 exam, they do give several questions from implant, and one of the question is this. Coming to another scenario that is about tongue, because the tongue is again the most important topic. I told you I'll be only talking about two topics. One was implant. I hope I'm clear in it. And another is tongue, embryology. They gave us a question from tongue embryology. I remember there were a few questions related to tongue as well there in my exam. So however much I remember, I have brought away here for you. talking about tongue. Beginning from the embryology, as I told you, the question is already about embryology, but if not about embryology, please begin with basic. Don't think that you are appearing on MCQ. Please study from basic. You can have question from any type. So, according to tongue development, the embryology of tongue, they give us a question that at what age does the tongue starts to develop? So it's 4th week of intrauterine life when the tongue begins to develop, and it develops from the pharyngeal arches. What are those pharyngeal arches? From where the tongue develops. The tongue, I think you remember the pharyngeal arches: pharyngeal arch 1, pharyngeal arch 2, pharyngeal arch 3, pharyngeal arch 4, and pharyngeal arch 6, not 5, because 5th pharyngeal arch is not present. The arches which are mostly responsible for the formation of tongue are pharyngeal arch 1, sorry, not this, pharyngeal arch 1, pharyngeal arch 3, and pharyngeal arch 4. If you see in this picture, you see that was actually a folded embryo. We got the section from the top of an embryo, and I have kept this section over there. The cut section or cross section I have kept over here. This is one side, this is another side. Like here, this is one side, this is the other side. I hope you will understand. So this picture is telling you the pharyngeal arch. If you see here, pharyngeal arch 1 with red, it's forming the tongue. Pharyngeal arch 3, it is also helping you to form the tongue. And pharyngeal arch 4, that also helps in making the posterior, very posterior part of the tongue, that is normally called as root of a tongue. So anterior part of the tongue, most of the tongue is formed by pharyngeal arch 1, then pharyngeal arch 2, and little from pharyngeal arch 4, or not pharyngeal arch 2, but pharyngeal arch 3, and little of the tongue is formed, the most posterior part, that is called as root part, that is formed by pharyngeal arch 4. What are the structures? They do give a question. The structures that are responsible in forming the tongue are, you see here, if you see, here is a swelling and here is another swelling. There are 2 swellings. These are called as lateral lingual swellings. If I make a picture like this, these are fate of the pharyngeal arch 1. These 2 lateral swellings and a single swelling in the middle, that is called as tuberculum impar. They all together help to form the anterior 2/3 of the tongue. Anterior 2/3 of the tongue is formed by these 2 lateral swellings and tuberculum impar. And from where do they come? They come from the pharyngeal arch 1. Now, it means after the 2/3, we need to have some part of the tongue left, means posterior 1/3. The posterior 1/3 is formed by a 3rd pharyngeal arch from a structure called hypobrachial eminence, also known as scapula. That helps in forming the posterior 1/3 of the tongue. The very posterior root of the tongue is formed by the pharyngeal arch 4. So this is the embryology of the tongue, that it means tongue starts developing from 4th week of intrauterine life. After understanding the tongue, we shall understand what are the muscles of the tongue. There are muscles of the tongue which are called as intrinsic muscles, and there are muscles that are called as extrinsic muscles of the tongue. The intrinsic muscles are those muscles, those are not attached to the bone. I did not talk about them over here. Extrinsic muscles are those muscles which are attached to the bone. Somewhere they're attached with the tongue, and at some end they're attached with the bone, like here, like here, like here. So we'll be only talking about the extrinsic muscles of the tongue. The extrinsic muscles of the tongue are styloglossus, hyoglossus. See, glossus, glow. You remember this word, glossus, gloss, tongue. Genio means genial tubercle. Glossus, tongue. Hyo means hyoid bone. The words are telling you. Glossus, tongue. Palato means with palate. Glossus, again tongue. Stylo means with styloid process. So these are attachment with the bone. Based upon those attachment, they are given some names. Palatoglossus, common sense, attaching to the palate. Styloglossus, common sense, attaching to the styloid process, like this. So these muscles are called as extrinsic muscles. Those muscles attached to the bone on one side and other side, they're attached with the tongue. These are called as extrinsic muscles. Intrinsic are those which are only attached to the tongue, emerging from the tongue, inserting into the tongue. So we are talking about these muscles. You just see, if I ask you, which muscle is responsible in helping protrusion of the tongue? Protrusion of the tongue. If I say, which muscle helps tongue protrusion? You see, the muscle who is having fibers somewhere coming like this from the base of the tongue and to the anterior region, giving this direction to the tongue. So don't you think that would be a genioglossus muscles? Because genial tubercle is over here. On the inner surface of the mandible, we have little projections. These are called as genial tubercles. The muscle attached from the base of the tongue till the genial tubercle, don't you feel from the direction of the muscle, we understand that this muscle will help protrusion of a tongue, like this. So muscles that help protrusion of the tongue is called as genioglossus muscle. Protrusion. Another muscle, if I say, what is the function of palatoglossus? You see, muscles are somewhere attached to the tongue and part of it is attached to the palate. Here, this is the palate. Part of it is attached to the palate. Will it help tongue go this direction, or will it help tongue somehow go this direction? Palatoglossus, as the fibers are from the base of the tongue, they're starting and emerging backward, upward. It means that muscle will help in elevating the posterior surface of the tongue. They are present somewhere here. They are attached to the palate. So they help the palate posteriorly to elevate. Come to the third muscle. Styloglossus. What do you think? Sometimes we have to use common sense in the exam. If I say the muscle for the protrusion of the tongue is a styloglossus, do you think the direction of styloglossus is going that way? Styloid is processed far back, and the fibers are going somehow like this from the muscles over here. Don't you think the fibers are retracting the tongue backward? Instead of protracting, it is retracting backward. The muscles helping the tongue retract backward. Then hyoglossus. The last muscles I'm talking about, hyoid. See, this is the hyoid one, and muscles attached is hyoglossus. The hyoglossus muscle is helping the tongue to depress. The directions are such that they are depressing the tongue downward. So when sometimes you do not read the things, but if you have a clear concept, you can answer the questions easily. These muscles, it's very important to understand their motor supply. Please, all the muscles of tongue, extrinsic as well as intrinsic, they are all supplied by different nerves. We will be talking about over here. And there are some exceptions of the muscles that are not supplied by the nerve, which supply all of the muscles, extrinsic muscles. Like if I say hypoglossal, palatoglossus, and styloglossus. These are the muscles of the tongue. They are extrinsic muscles of the tongue. These all muscles are supplied by cranial root of accessory nerve, as well as all the intrinsic muscles. Styloglossus, hyoglossus, and palatoglossus, sorry, not palatoglossus, hyoglossus, styloglossus, and hypoglossus. They are all supplied by accessory nerve, an accessory cranial nerve. Step the palatoglossus. The palatoglossus muscle is not supplied by accessory cranial nerve, but that is supplied by cranial number 10, vagus nerve. That supplies the palatoglossus muscles. This is the questions they gave in the exam, that all the extrinsic muscles are supplied by the accessory cranial nerve. No, except the palatoglossus. So that was all about the muscles and muscle supply. Now coming to the taste, sensation, and sensory fibers of the tongue. If I told you that most of your tongue, anterior 2/3 of the tongue, is formed by branchial arch 1. The posterior 2/3 is by brachial arch 1. The posterior 1/3 is by brachial arch 3, and most posterior by brachial arch 4. The tongue has special sensory and motor supply. The sensory supply to the anterior region is different than the sensory supply to the posterior. The taste supply to the anterior is different, and the taste supply to the posterior surface is different. So the taste supply for the anterior region, as I told you, is different than the posterior. The fibers of the facial nerve, chorda tympani, supplies special sensory supply to the anterior surface of the tongue. And the taste supply to the anterior surface of the tongue. Whereas the lingual nerve of cranial number 5, a branch of mandibular division of the trigeminal nerve, supplies the sensory sensation to the anterior 2/3 of the tongue. The posterior 1/3 of the tongue now. For the posterior 1/3, we have the taste fibers coming from the glossopharyngeal nerve, and the sensory fibers are again from the glossopharyngeal nerve. The most posterior part of the tongue, which we said that was formed from the 4th pharyngeal arch, that is supplied both for taste and sensation by vagus nerve. See, only the difference is in anterior region. The motor supply, the taste fibers and sensory fibers are different for the anterior 2/3 of the tongue. But for the posterior 1/3, both the taste and sensory fibers are from the glossopharyngeal nerve. So the difference is only into the anterior 2/3. You need to remember that the taste fibers are of the chorda tympani, a branch of the facial nerve, and the sensory fibers are from the trigeminal, a mandibular branch of the trigeminal nerve that is called as lingual nerve. It's Very necessary that you shall remember all the cranial nerves by their name. I have made this mnemonic because it was very easy for me. I remember the cranial nerves like that. Are only object to taste and fun. Very good when at hospital. So with those, I made like O for olfactory, then optic, then oculomotor. You just take the first alphabet of it and just match it. So I'm not doing in detail of it, but it's very easy to remember with this mnemonic or whatever mnemonic you have. It's up to you. But for me, it was very easy to remember these. Because when you remember the names of the cranial nerve, that it somehow you will have a clue about, you know, some of the questions you can solve if you remember the names. So that also gives you a clue to solve the problem. After the muscles of the tongue, the embryology of the tongue, the supply of the tongue, we shall come to a main function of the tongue, that it carries the taste fibers. It has a taste buds. So where are those taste buds present? There are different type of papilla present on the tongue. This is very essential because tongue has a very, very, very special role in having taste fibers, you know, in giving a sensation for the taste. So there are, first of all, we will understand there are different type of papilla present on the tongue. The papilla which are present over here and they are dome-shaped papilla, they are called as circumvallate papilla. They are present most posteriorly. On the edges of the tongue, there are another papilla on this border, on the little away from the midline, and not exactly on the lateral surface, but in between these two areas, in midway between the most lateral end and mid portion, there are papillas which are called as present fungiform papilla. Then there are some papillas which are present on the near, you can say, to the midline of the tongue. They are called as filiform papilla. On the lateral surface of the tongue, little posteriorly, you have papillas present that are called as foliate papillas. So these papillas are very important to know because they are having taste buds present. Out of these papillas, which papilla has a taste bud present? These papillas, the circumvallate papillas, are the one which have taste buds present. And these taste buds carry the taste impulses from the circumvallate papilla to the hypothalamus. From the hypothalamus, then it is a relay station. The hypothalamus will tell the cortex that such taste has reached. So the fibers or the taste buds are present in the circumvallate papilla. The impulses generated from the taste buds, they reach to the hypothalamus and then they are transferred to the cortex. Now, after knowing all about the tongue, you shall know what is the normal tongue, what are the problems of the tongue. You can have ulcers on the tongue. Tongue can have a lot of other pathological conditions like oral candidiasis, squamous cell carcinoma. There can be geographic tongue, fissure tongue. Believe me, they are very, very, very important because in part 2 exam, they give several questions from the tongue. That's why I brought 2 topics which I felt very important, although all others are also. Inshallah, in future, I'll be making videos for you. But the most important, hopefully even the upcoming exam, you will have questions from implant and the tongue. So one of the condition, I brought the clinical presentation. What do you think this condition is? This is oral squamous cell carcinoma, the squamous cell carcinoma of the tongue. In MFD2 exam, they give you a scenario because there we have to write. So they ask you, you shall know how to write. They say, what is the clinical presentation? So you say a non-healing ulcer with indurated center, the means depressed center, the elevated borders present from so and so days based upon the history, and giving trouble in eating, and it bleeds when it gets a little touch, giving problem of swallowing, is called squamous cell carcinoma. So in MCQ, they can give you a non-healing ulcer present on the lateral border of the tongue from so and so days. What is it? Squamous cell carcinoma, oral aphthous ulcer, or it is candidiasis, whatever. So you shall understand what is an oral squamous cell carcinoma. This is actually cancer when ulcer for a long time present and it's not healing. It has a pseudomembrane over it. It has a depressed base. It easily bleed. It causes problem with the taste. It causes problem with the eating, inability to swallow, and sometimes otalgia. So this is, and also retraction of the movement, difficulty in speaking, difficulty in talking. That ulcer is most likely a squamous cell carcinoma. Here I brought several questions from the tongue. We discussed the tongue. Now, a muscle that helps in protrusion of a tongue. I told you genoglossus, because muscles is attached from the lower surface of the tongue and going into the anterior direction, attaching to the genial tubercle. A question, hypoglossal nerve supplies all the muscles of the tongue except, I told you all the muscles of the tongue were supplied by an accessory, hypoglossal nerve supplies all the muscles of the tongue except, that is palatoglossus. Over there, I did a mistake. I feel that here I told you that accessory nerve, that is a motor supply for the tongue. Okay, all the extrinsic and intrinsic muscles of the tongue are supplied by hypoglossal nerve except the palatoglossus. Palatoglossus is not supplied. Sorry, here I did mistake during explanation. All the muscles of the tongue are supplied by hypoglossal nerve except the palatoglossus muscle. The lymphatic drainage, they do give, please do see this. This was the question in exam. And this was the question in the exam. The lymphatic drainage of the tip of the tongue goes where? The tip of the tongue drains into the submental lymph node. If they give you question that lateral surface of the tongue drains, it drains into the submandibular lymph node. A question is there, when patient protrudes his tongue, it deviates to the right side. Which nerve is damaged? If there is a damage to the nerve, the tongue will move to the affected side. If the patient protrudes the tongue and tongue deviates to the right, it means there is problem with the right hypoglossal nerve. I have a question. Impulses generated from the test fibers go to the cortex via thalamus. We have discussed this. In which of the following papilla does the taste bud rely? I told you the circumvallate papilla are the one where the taste buds are present. Where are the circumvallate papilla present? I told you this is the area where the circumvallate papilla present, and that is actually circumvallate papilla. Behind quickly the circumvallate, these are the circumvallate papillas. Quickly behind it you find a little circular sulcus is made, that is called as sulcus terminalis or terminal sulcus. The papilla, the circumvallate papilla, are actually present front of the sulcus terminalis. These are the papillas and they are present in front of sulcus terminalis. All are the structures lying deep to the hypoglossal muscles except. When you see the diagram, you will understand. If you see the hyoglossus muscles, in that all the structures, these structures are present into it except the hypoglossal nerve. The papilla present on the margins of the tongue, I told you the margins of the tongue, they are called as fungiform papilla. The anterior two-thirds of the tongue arise from, I told you, two lateral swellings and one median swelling of the pharyngeal arch 1. So those were called as lateral swellings and tuberculum impar. The extrinsic muscle that aid in depressing the tongue, it depresses the tongue downward also. If you see the direction of genioglossus muscle and hyoid bone help in depressing the tongue, and the genioglossus, it protrudes the tongue as well as it depresses the tongue. Structure related to the medial surface of hyoglossus muscle include hypoglossal nerve. The mucosa of posterior third of the tongue is supplied by, I told you, the mucosa of anterior, the mucosa of posterior. The mucosa of posterior tongue is supplied by glossopharyngeal nerve, as well as the test fibers are also carried by the glossopharyngeal nerve. The muscles of the tongue are supplied by hypoglossal nerve. It did not say all the muscles. If it would have said all the muscles of the tongue are supplied by hypoglossal nerve, we would have said no, because palatoglossus is not supplied by hypoglossal nerve. The tongue develops from, I told you, pharyngeal arch 1, pharyngeal arch 3, and pharyngeal arch 4. The sensory fibers of the posterior 1/3 of the tongue is carried by cranial number 9. And which is cranial number 9? Cranial nerve number 9. 9. Very good, Van. Good, Van. The good is glossopharyngeal. If you know the mnemonic, you will understand quickly what is it talking about. So the posterior nerve sensory fibers of the posterior 1/3 of the tongue are supplied by cranial number 9. Palsy of the right genioglossus. The muscle genioglossus, if it is paralyzed, the tongue will deviate to the affected side. Taste receptors are which kind of receptors? They are actually chemoreceptors. The taste sensation is carried by all except. What are the nerves which were carrying the taste sensation? Glossopharyngeal was taking it from the posterior 1/3. Facial nerve was carrying it from the anterior 2/3. The most posterior was carried by vagus nerve. So it means the trigeminal nerve is not carrying the taste fibers. It gives the motor supply, not the special. The action of styloglossus muscle, I told you from the styloid process, if you remember the picture, coming to the tongue, when the muscle is coming from posteriorly from the styloid process and attaching to the tongue, don't you think it will take the tongue posteriorly? It retract the tongue posteriorly. The lymph from the tongue not drained by following vessels. This is some additional question I've given you. You can just read it out. The ventral lymph from the tongue not drained by the following vessels, the ventral, but the rest of them, posterior, central, and marginal, they do. I hope this is enough for you, even enough for me in explaining. I do my best to help you guys. Please stay tuned with me, inshallah. As soon as I make the other videos, I'll upload that. And you please like and subscribe my channel in order to have notification that whenever I, upload any of the videos, then you will have a notification you can easily see. Thank you so much for watching. Thanks a lot.